Thank you, Ricardo, for that kind introduction. I could understand some of it. We're going to talk on embryo selection, and it kind of extends on some of the things we began talking about yesterday. Here are my faculty disclosures. Nothing really pertaining to today's talk. So, when we started doing IVF many years ago, as I said yesterday, we didn't have the luxury of cryopreservation. So it became very important, if we had a number of embryos, to be able to pick the embryo that was most likely, or the set of embryos that were most likely to result in a successful pregnancy. And that early embryo selection was based on the morphology of a cleavage stage embryo. And initially, we would be transferring, back in the old days, 3, 4, 5 embryos. I was talking to Dr. Ash about when we used to do gamete interfallopian tube transfer. We'd be putting, 6 eggs or so or more in the fallopian tubes. So we were less worried about multiple pregnancies back then. We were just worried about people achieving pregnancy. Of course, back in those days, we only had about a 12%, 10 to 12% pregnancy rate for routine IVF, transferring that number of embryos. And of course, the advancement of our laboratory techniques and cryopreservation has changed all of that. First change, I think, was probably the use of extended culture to blastocyst. Extended culture to blastocyst itself is a method of embryo selection because only the most robust embryos will survive till day 5. The issue is that this extended culture doesn't make embryos better. It just identifies embryos that are strongest and most likely to succeed. So if you have a number of embryos, it's a method of selection. I had, when Dr. Gardner first came out, the idea of blastocyst transfer, we had a secretary who'd gone through several embryo transfers, IVF cycles, and was not successful. And she said, please do this, extended culture to blastocyst. And of course, none of her embryos survived to blast, so she didn't have a transfer. And that was when we started, understanding that this is a method of selection, not a way of making embryos better. So extended culture does not improve the intrinsic quality of embryos, it's a selection method. And embryos that fail to make it to blastocyst, that are presumed less likely to implant result in live birth, might have implanted had they been transferred on day 3. And in our patients who are a median age of around 44, we oftentimes will transfer cleavage stage embryos, oftentimes of rather low quality as normally graded by the embryologist. And surprisingly, we get healthy babies from those transfers. So the only way to ensure that your patient doesn't achieve a pregnancy is to not do a transfer. So as we said, blastocyst stage transfers yield higher implantation and live birth rates per transfer compared to cleavage stage transfers, and largely because those that survive are developmentally more competent. But as people get older, they're less and less likely to have a blastocyst. So predominantly in our practice, we're still doing cleavage stage transfers. The studies show that extended culture doesn't alter ploidy status or genetically improve embryos. So those that make it just were stronger. Some studies, including randomized trials, suggest that extended culture could reduce cumulative live birth rates, particularly in poor responders or older patients due to the loss of embryos. So today, when we have excellent cryopreservation, where you can freeze the whole cohort of embryos, whatever they are, that you retrieve, you have the ability. The important thing today is not necessarily the pregnancy rate of the first transfer, but the cumulative pregnancy rate, because our goal here is to try to help our patients have successful pregnancies. In one of the earlier Cochrane reviews, they actually found that the cleavage stage embryos had higher pregnancy rates. Subsequent Cochrane reviews have shown that the pregnancy rates or cumulative pregnancy rates are more or less similar between cleavage stage and blastocyst transfer, some of them showing slight improvement of blastocyst transfer. So if you need to do PGTA, the clinics would prefer to do they have to culture to blastocysts to do a trophectoderm biopsy. And then in order to have better synchronization with endometrial receptivity or single embryo transfers, they do the, obviously need blastocyst transfer and frozen embryo transfer. So thus far, if you're thinking of cumulative pregnancy rates, we haven't really shown that embryo selection makes a big difference beyond basic morphology. And there have been no consistent improvements in cumulative outcomes. Which comes to AI. So with AI, we can sample multiple images in the extended culture under techniques that capture these images, and we can feed lots of data into the AI tool in order to try to help us select which embryo is most likely to succeed. And the goal for this would be to increase the likelihood of pregnancy in that first embryo transfer, because obviously in terms of cumulative pregnancy rate, you can't change, you're not improving the whole cohort. The cohort is set. The embryos that you froze are the embryos you're going to use. So all you can do is try to improve that first embryo transfer. Some of the AIs are working on guided indicators that the investigators use to direct the AI. Some are just collecting data as sort of a deep AI, artificial intelligence technique, and training the AI on multiple cases. These artificial intelligence for embryo selection seems to do well when there are many embryos, but of course in older patients like those that I would take care of, it doesn't really make too much difference. It may be harmful. Illingsworth published in 2024 a large study using the the IDT artificial intelligence technique, and they proved that artificial intelligence was not inferior to the traditional morphology assessment by the embryologist. They basically showed that they were the same. They did show that when you used artificial intelligence, it took much less of the embryologist's time, statistically different. And they emphasized that. I think it was a P009 or something like that, statistical difference. The difference was that with the AI, it took 21 seconds for the embryologist to pick the embryos for transfer. And without the AI, it took about 3.5 minutes. It saved about 3 minutes per transfer. If you're doing 10 transfers a day, it would save your laboratory about 30 minutes of embryology time. Kieslinger also looked at the combination of AI and time lapse and showed that there was really no clinical benefit in terms of live birth rates between the two. So as we said, cumulative outcomes matter more. The success is going to be a combination of the size of the cohort and the embryo quality that you produce. And embryo selection may shorten the time to pregnancy if you have many embryos and you can select the right one. It's unclear whether actually there's no data, no solid data in large studies that shows that artificial intelligence using embryo selection is significantly better in terms of outcomes when selecting embryos. The idea is that sibling embryos have similar potential. There can be some differences in cohorts between patients, but ranking adds limited value. Extended culture and epigenetics, culturing to blast can cause some epigenetic changes that can relate to pregnancy success, preterm, and some placental issues. So some of the problems, there can be an emotional toll. If you have a patient who's told she has her best embryo and she's had several of these best embryo transfers and she's not successful, the patients get demoralized. Also, if she's told that her embryos are of low quality, that can be very demoralizing for the patients as well. What we have done in our practice, which is mostly dealing with older patients with diminished ovarian reserve, is to focus on improving egg quality and cohort yield. We prefer to do cleavage stage embryos for poor responders, and we avoid unnecessary testing in these people when they only have a few embryos. So what should replace embryo selection? We need to prioritize the potential of the whole cohort. We can use morphology as a basic filter, and we need to improve pre-retrieval interventions. So just a few words on where we think artificial intelligence may take us. Here in Mexico City, you had the first baby born via a fully automated ICSI system. It's an amazing use of artificial intelligence. Of course, we can have a highly trained embryologist to do this, but if you can have an artificial intelligence system, perhaps you can do these processes faster and save time and money. We had a very interesting talk yesterday by Dr. Ibarra from London, talking about using artificial intelligence to look at selecting or look at the ovulation induction. And we've had a similar experience in our practice. So one of the things we noted is that as women got older, there was evidence that there was earlier luteinization of granulosa cells, and that we could avoid that earlier luteinization by doing our retrievals earlier. In our practice, we would retrieve a woman who's less than 38 years old in the normal sort of 18 to 20 range. But then as people get older, we would successively retrieve at smaller and smaller follicle sizes. The thought is that in the future, one could use artificial intelligence, collecting information from automated ultrasound images, look at things that we don't see apart from follicle size to possibly further improve timing of ovulation induction. we have been looking sort of manually at some of these things. So if you look at this follicle, which is on day 12 of stimulation, you can see a very smooth border along here. And what we noticed is that, oh, I'm sorry, go back. What we noticed is that if you see these hyperrefringences along the edge, which show up in these follicles when they're just pre-ovulatory, we're calling these pearls. And what they represent is the border of the follicle beginning to break down and preparing for ovulation. And we've been looking at this in all of our patients. In our older patients, we see these changes at earlier follicle sizes. We've seen it as early as, say, 12 millimeters, even 10 millimeters in some. And when we do retrievals based on a combination of following the follicle size, their age, and these observations, we're getting mature eggs and embryos that we can transfer, even these older patients. Our experience when we used to do everybody at an 18 to 20 millimeter follicle size was that we'd often get atretic eggs that are no longer really usable when you do extended culture, extended stimulation under a agonist or antagonist suppression. In our practice now, we use no antagonists and we rarely use agonists. We only in patients who are making a lot of follicles, we might use either a microdose Lupron or a sort of a half dose of an antagonist, like 125. But most of our patients are using none at all, and we're just using highly, very close observation of follicle characteristics. And of course, if we're doing this with RI, artificial intelligence system that could collect under a standardized ultrasound scanning could do this perhaps much better. So the point is that the cohort of embryos that you have has a predefined possibility of success. Picking a particular embryo can possibly decrease the time to your first successful pregnancy, but ultimately can't influence your cumulative pregnancy in the face of good embryology and cryopreservation. Lastly, I just want to note, we're doing cleavage stage transfers, and if you go back to this article by Kissen from the CDC, it's a rather old article, and he was looking at the number of embryos transferred with good perinatal outcome, defined as a singleton ongoing pregnancy live birth. As you can see, as women got older, even transferring many embryos was simply increasing the likelihood of having a singleton pregnancy, because the chances of an individual cleavage stage embryo of a woman in her mid-40s achieving a successful pregnancy is very small. So doing single embryo transfers on these older women really doesn't make any sense. So embryo selection beyond morphology has yet to be proven. It adds cost and complexity. IVF outcomes need to be patient-centered. In other words, we need to maximize cumulative pregnancy rates for our patient and use precision medicine to try to do better. So thank you. These are my fellow workers at CHR. This is a picture of our office. And as I told you before, we have a meeting coming up in December 2025, and there's a QR code if you want more information. Thank you very much.